And as a reminder, we do record these. They'll be available later for those who can't participate or, will miss part of it. But we do turn the recording off at the end of the presentation so we can all talk comfortably and openly. So our agenda today is understanding MDROs. So what exactly are we talking about, especially in relation to high-risk MDROs? We're going to talk about carbapenems. Why are they important? That class of antibiotics. We'll talk about these emerging pathogens threats in Oregon and how we're managing them, what they mean. We're going to dive a little bit into antimicrobial resistance, and then also, near and dear to our hearts in infection prevention is what are some of those practices that we can implement as part of our routine operating processes in a facility to prevent transmission. And then we'll also be providing resources. A lot of the resources are going to go out in the follow-up email that I send out with the links. So don't get too nervous. If you aren't able to pick up on all of those. So just a background. So these segments of Power Hour are dedicated to the high-risk multi-drug resistant organisms. And essentially, there are two large categories that we're talking about. The first is the Carbapenemase-producing organisms, or the CPOs. We love our alphabet in infection prevention and infectious diseases. So we'll be working to help really understand and explain what those are. And then the other is Candida auris, which we will not be talking really about today. We will be focusing on Candida auris in November. So today is dedicated to CPOs. So we'll talk now about really understanding MDROs and what really matters to us. For those of you who know me pretty well, I've been in infection prevention for quite a long time. And when I first started in infection prevention, I was really working on the right side of this umbrella. And it was around the time where MRSA really became concerning, along with VRE. And then after a little while, we started seeing issues around ESBLs and C. diff. So, it's really been building into what I often call is March of the Alphabet. And now our alphabet has moved to the left side of the umbrella for CRE. CRA, or what we used to call for us more seasoned IPs, which is CRAB. And then what are real high-risk HR MDROs are the CPOs, Carbapenemase-producing organisms, and C. auris. So it's important to know that we partner you and our local public health agencies, and the local public health conducts the case investigation and needs response for those reportable organisms. And I'll include a link to the revised list of the reportable organisms. But the MDRO team here at OHA usually takes lead in the response for these two targeted organisms. So we become very involved, and I'll talk a little bit more about that as we move along. And I do want to emphasize that when we talk about outbreaks, 2 or more cases is what we would identify as an outbreak for any of the MDROs. So I strongly encourage you that if you're seeing clusters, outbreaks of these organisms, to reach out for another set of eyes that can help you sort of tease out what might be going on. So I want to start to talk a little bit about what are carbapenems, what is it about that drug class that's important. So I like the mnemonic MEDIC. So MEDIC is the first letter of each one of these carbapenems: meropenem, ertapenem, which isn't used quite as much in the US. I think we stopped using it around 22 or so, but doropenem and imipenem-silostatin. So that's a medic, but I love one of my partners, Heather. She's much simpler, and she says anything that ends with a penem is a carbapenem and deserves us paying attention to. And the reason why carbapenems are so important to us in infection control and infectious diseases is they're very important for the treatment of severe, complicated, and resistant infections. And that's because they have a very broad spectrum of activity, antimicrobial activity against both gram-positive and gram-negative organisms. And I did put a little image down at the bottom for gram negatives, which are pink. They stain pink when they're looking at them in the lab, and then the gram positives, which are the purple. So they are also considered commonly one of our last resort antibiotics, and that's because they remain effective against many types of organisms that are resistant to other antibiotics. They're also safer. While they do have some complications, they have fewer adverse effects when we compare them to some of those other last resort antibiotics. So that's a bit about the class of carbapenems. They have an extremely broad spectrum of activity and are the drug of choice for infections that are caused by extended spectrum beta-lactamase producing organisms, or those ESBLs is really what we normally refer to. And on the right-hand side is another mnemonic, just kind of covering those organisms that are typically more commonly identified as ESBL. So Serratia, Pseudomonas, Proteus, Providentia, Acinetobacter, Citrobacter, Enterobacter, and Morganella. So if you want, as you're looking at your micro results, and you want to remember which are the ones that tend to be more likely to be ESBLs, remember that's mnemonic space M. Also, there are gram-negative organisms that are more commonly resistant to carbapenems. And that happens through a variety of ways, but you can think of two mnemonics, SPAM and CP, to identify which of those gram negatives are most likely to be resistant or more likely to be resistant to carbapenems. So Stenotrophomonas, Pseudomonas, and the atypicals, such as Legionella, Chlamydia, and Mycoplasma. And also it's important to know that MRSA is not, carbapenems are not effective against MRSA. So the CP, when you see CP and another set of letters identifying what the organism is, it's helpful to know that CPs will not, organisms identified as a CP, which means carbapenemase producer, will not work against organisms, carbapenems. And I'll talk a little bit more about why that is. So I wanted to touch a little bit on carbapenem resistance. So carbapenem-resistant organisms is a term used to segregate a whole group of organisms that are resistant to carbapenems for a variety of reasons. And resistance develops in a number of ways: vertically, where it's transmitted, maybe they pick up a genetic, a gene for resistance, and that gene gets transmitted from parent to offspring. And then there's three methods that are referred to as horizontal, and not going to go into them because frankly I can't speak very intelligently about them. It's a little complicated. One is transformation. Importantly for us, that we'll talk more about, is conjugation, which is direct cell-to-cell transfer of resistance information. And then the third is transduction. So we'll sort of leave it at that. But essentially, one of the points I wanted to make is that bacteria, viruses, they want to survive. So they are very adaptable in evolving ways to protect themselves from the effects of antibiotics. And that's part of why I find all of this quite fascinating. But this carbapenem resistance is especially important because they are so vital to us as last line antibiotics. So when we start talking about CPOs, or carbapenemase-producing organisms, they are a subset of that larger classification of organisms that we call carbapenem-resistant. And that's because they have a bit of a unique way of fighting or combating this class of antibiotics. So carbapenemase is again a mechanism that they use to protect themselves from carbapenems, and it's through enzymes that are produced by the bacterial cell that actually degrade the carbapenem antibiotics. I used to say carbapenemase organisms eat carbapenems for lunch. So they're seriously ineffective. They're also, this method that the bacteria use is easily spread among other bacteria, particularly, the gram-negatives, and I'll explain that a little bit more. And sometimes you'll hear us talk about the different mechanisms, KPC, NDM, OXA48, and VIM. And that just essentially identifies the mechanism or the gene that the organism is using, that the organism is acquired, is being identified. And it doesn't change how we approach those organisms, but it does give us a little bit more information about, clusters or transmission, that kind of thing. So then the question is, okay, so I have a carbapenem-resistant organism on my lab report. How do I know if it is a carbapenemase-producing organism? So you might get a lab report that says CRE, and that is a carbapenem-resistant enterobacterales. What happens once that's identified is there's a bit of a reflex test where they go in and they look to see, okay, it's resistant to carbapenem. Is it producing an enzyme, the carbapenemase enzyme, in order for that resistance to happen? And the way that you would know that, and sometimes there's a bit of a delay, is that the report will come out as CPCRE. Sometimes that can happen fairly quickly. Sometimes there can be a little bit more of a delay. So CPCRE, CPCRA, Acinetobacter, or what we used to call crab, and then CP Pseudomonas aeruginosa. So that's kind of how you would identify the difference. Do you want to talk a little bit about how resistance develops? I like this image. It's, the cross-section of the organism, and it shows, the cell wall and the membrane and the ribosome and the pilus and, all of those little pieces. But what really matters for this part of the conversation is this little plasmid that I've circled here on the slide. And the plasmid in a gram-negative organism is what it contains a mobile genetic element within the bug. And within that plasmid, there are instructions for the cell to be able to produce the carbapenemase to protect itself. Now, these plasmids are very concerning because they can be easily shared among bacteria. And if it's say a Klebsiella, not only can it be shared with other Klebsiella organisms, it can also be shared with other gram-negatives. So this is what has led to the rapid spread of antibiotic resistance within these gram-negatives. So here I have one of my favorite electron microscope images of this process actually occurring, and it's called bacterial conjugation. And what happens during that process, it's, I like to call it unsafe sex between microbes, but it's when the transfer of that plasmid, that little golden nugget there, from one cell to another. So in this image, we have a donor bacteria, which is Pseudomonas, and then the recipient bacteria, which is E. coli. So essentially what happens is the donor organism, calls out for a hookup with another organism and says, hey, come over and hook up with me. I've got a golden nugget for you, and is able to then spread that resistance info, or share that resistance information with the recipient bacteria. So that is really what provides for ease of spread through the different species of gram-negative bacteria. I want to give you a little bit of a quick image. I'm not going to spend a lot of time on this, but show about 17 years worth of spread of a particular type of a CPO across the US. Excuse me. So starting in 2001, we see our first cases on the East Coast of the United States. New York, I think maybe, actually it looks like it's just New York, and then southern, I don't know which state that is, isn't that awful of me? North Carolina, I think. And then, within 8 years, we have spread by 2010, 9 years through most of the Eastern US, Southern US, and Southwest US. And then 7 years later, we've seen these KPCREs in every state in the United States. So, or continental, actually, I guess. Yeah, continental and every state in the US, you can see down here at the bottom of the screen where it's Alaska and the Hawaiian Islands. So I'm just touching on, what's happened here in Oregon. So starting in January 2011, we saw our first cases of just a straight CRE, and 3 cases. And you can see that there's a general upward trend over time to where we have 211 cases identified in 2023 and 68 cases through May 31 of 2024. So fairly recent data. And then looking at that subset of CRE to the CPOs, we can see that we had our first case, just one in 2010, and we had 2 in 2012, 1 in 2013. But particularly since COVID, we've started to see an increase in these isolates being identified in our labs. We're still so much better off than most of the other US states. 20 cases is a huge amount, but it's not a trend that we want to see continue. The different colors highlight what mechanism that organism uses, and those are identified as the purple being Vim, IMP. You can see we don't see much of that, just 20, 21, and 22. Then OXA and NDM and KPC, which we see most commonly. Anywhere where you see the stripes, then we've identified an isolate that carries 2 mechanisms. So for instance, in 2023, we saw one organism that had both OXA48 and KPC expressed. So it's important to know that beyond what you all are doing with your robust and important infection prevention program activities, that there's a lot going on behind the scenes to prevent spread of these organisms. And most importantly to me, it's personal, is the expanding OHA-HAI team. And that includes, an additional, now we now have 2 epidemiologists for multi-drug resistant organism surveillance and response, And now we also have 2 infection preventionists, one for Western Oregon, one for Eastern Oregon. And also we have an MDRO, antimicrobial stewardship, pharmacist that we work with, who's absolutely wonderful, and I'll share her resource information towards the end. We also have available the ARI alerts for emergency departments and skilled nursing facilities, so that when a patient is admitted, you can see if they have an MDRO history. Don't know a lot about that program. I believe it's free, but if you have questions about it, just email me and I'll try to link you up with people who know a little bit more about that program. And then there's also investments in new technology at the Oregon State Public Health Lab, or OSPHL, for improved testing capabilities. And part of what we're doing here is really supporting our local public health agencies by providing targeted training on both CPO and C. auris prevention and response. Now, the last bit is sort of what we're going to highlight and dive into for the remainder of this presentation. And it's really working closely with facilities that are experiencing CPO or Candida auris, or proactively by preparing high-risk settings or any healthcare settings, really to improve infection prevention practices so that we can, always be working to prevent the spread of these organisms. It also includes assisting with antibiotic stewardship programs, which is an incredibly important part of these efforts. And then we also provide responsive work. And that involves our MDRO MDRO epidemiologists in partnering with us to support facilities where cases are identified. And this also includes the screening of patients and residents. And then also it will always include a responsive iCard to support and review your infection prevention practices and see if we can brainstorm ideas that might make care safer. So, some things about both CPO and Candida auris, which again, we'll talk more about in November, is that they tend to spread silently. And they do that efficiently when they're able to exploit the gaps in our infection prevention or control programs. So hand hygiene, donning and doffing, cleaning and disinfecting, offer them invite opportunities for spread. These organisms also affect the most vulnerable in our populations. Those individuals who have multiple and prolonged healthcare stays, those who have invasive medical devices, ventilator-dependent populations, and any individuals who have recent or frequent antibiotic and antifungal treatments. So yeah, it's just not good for folks who need a lot of medical intervention and medical care.
Therese?
Yes.
This is Sandra. We have a question in the chat.
Sure.
From Patricia Paruch. She's asking, where are most of these organisms being found? UTI, blood, or skin?
You know what, can I delay questions until the end, Sandra, please?
Sure, absolutely.
Sandra? Okay. Yeah, because I may answer that as we go on. So one of the challenges that we have when we begin talking with people, whether it's patients, residents, or staff, is that it can trigger a bit of a fear response. So how we speak with folks about this is really important. And I always tend to emphasize that, number one, these organisms live in our gut, and often without symptoms. So I could have this in my gut and I wouldn't know it, and it doesn't cause any problems. These gram-negative organisms are part of our normal flora, and they help us with our immune system to digest our food. They're very important, many of them, to us. But it's when these CPOs, these gram negatives with this enzyme get out of the gut and into a place where it shouldn't be on the body, such as in the urine. That's where I've seen the majority of positive isolates come from. Bloodstream, the lungs, wounds, and they cause an infection that can be incredibly difficult to treat. As I mentioned before, they spread silently, and really transmission is preventable with good infection prevention and control practices. So when talking with people about this, I always try to make it personal, provide very targeted and specific patient education. And I also take kind of a what's in it for me approach. If I was a patient in a bed in a hospital not feeling so well, and someone came in and said, we think you've been exposed to a CPO and we want to take a rectal swab because the state wants to keep track of how many people have this, I would say, no, thank you. But when we go in and we talk about it as far as an impact for you, it can be more persuasive. You know, how we talk about it really matters for our patients. So now I'm going to talk about some particular infection prevention strategies that I would like you to think about. And the first is really to strengthen your infection prevention bench program. And that's through policy and procedure. It's important to have a response plan for a first case. I strongly encourage you to work with your frontline staff and educate them as to what happens when this first occurs in our facility. Also, you want to grow your IP expertise within your walls of your facility. And, you know, the first thing you can do if you're a long-term care facility or, you know, ambulatory surgery facility, you know, get your IP designated person the CDC certificate. It's a great place to start. And then you can progress on through a associate in IPC, a long-term care focused certification in infection prevention, or the CIC. All education, make sure that you're educating your staff about this ahead of time so that it's relevant to what they're doing in their day-to-day operations, and they understand why those basic IP practices are important. Make it interesting, interactive, and fun wherever you can. I have a great Jeopardy program for infection control. I've seen folks do scavenger hunts, and I've never participated in an escape room, but it sounds like that could also be a lot of fun. So just get creative and, you know, get people participating. One of the most important aspects of control, aside from what we do with our patients, is the communication strategies. It's really important that you have chart flagging and that chart flagging moves with the patient from your walls to the next walls, doors that he or she goes to. So we want that flag to be transportable. Handoff reporting for these HR MDROs is especially important, and I strongly encourage that you do both phone and written communication to facilities receiving patients with MDRO. As you are looking at your practices and you find those gaps that allow for transmission to occur, include the corrective action in your daily huddles. Say, hey, you know, I did a little bit of hand hygiene yesterday and I noticed we missed some opportunities. Y'all get out there and make sure you're doing your hand hygiene. However, you can, you know, communicate those key performance requirements or needs. And then the other thing I just want to mention is the patient or resident wallet card. And I think I'm going to talk a little bit more about that. But what I'm getting at by mentioning it here is that our patients can be the most important advocates for themselves, other patients, and infection prevention. So by adequately educating them and giving them the tools they need to communicate to other providers that they see that they have one of these HR MDROs is a really valid and valuable way of extending you as an infection preventionist to your patients and residents. I want to thank Liz Breitenstein. She basically fed this slide to me, and it's great. When I first looked at it, I thought, oh, okay, look at all those Ds down there on the left-hand side of the slide. So if we're thinking about a stewardship report card, straight Ds make you the top of the class. So I'll just run through them. The 5 key principles are diagnosis, treat with antibiotics only when they're indicated. And that's a challenge sometimes in long-term care. So one of the things we can do in the future is really brainstorm, how do we manage reducing unnecessary antibiotic exposure, for instance, in urines in long-term care. Drugs, how do we select? We need to select the narrowest spectrum effective antibiotics. For the dose, we want the lowest dose appropriate for the condition and the patient. We want to use for duration the shortest duration recommended by published treatment guidelines. And then we want to de-escalate, and that is adjust drug selection when the appropriate information is available through the clinical condition and laboratory results. Okay, we don't ever talk about hand infection prevention and not talk about hand hygiene. So we want to monitor hand hygiene compliance. I would suggest that anytime you have a new CPO, a new Candida auris, or any other highly resistant organism, you actually increase your compliance monitoring, not only with hand hygiene, but also transmission-based precautions and cleaning and disinfecting. I always talk about engineering the environment, and that's because what we want to do is make it easy for people to do the things that we want them to do. And a big part of that is ensuring that alcohol-based hand rub is available at the entry to rooms and apartments or between beds in multi-patient rooms. It's also important to ensure that alcohol-based hand rubs are readily available in common spaces and in our dining rooms. And one of the reasons for that, in particular, is that, folks with cognitive impairment and physical limitations can really have a lot of difficulty with toileting. So they need a lot of prompting and support in performing hand hygiene after toileting. And then we also, if they're not performing good hand hygiene, we want to avoid them coming into our common spaces, in our eating areas, in our community activities. So including residents in those hand hygiene opportunities are really important and a valuable way to reduce environmental contamination. So all of this is really part of what I like to call creating a hand hygiene culture that includes your staff as well as your residents. Patient care strategies, I mentioned already the MDRO chart flagging and interfacility notification. That's so important that I just wanted to throw it up here again. Patient education is really important, and ensuring that we strictly are adhering to standard and enhanced barrier precautions for residents, or if you don't put every MDRO in your hospital on precautions. So, the warm, wet, and not yours of standard precautions can go a long way in driving barriers in acute care as well. So just keep that in mind. And it's especially important in long-term care because we know some literature are identifying more than 60% of long-term care residents being identified with an MDRO. So it's already a population where we're seeing a lot of these. Another potential strategy that we can be thinking about is what are our routine resident skin hygiene practices? For CPO, there is good literature that shows that the targeted use of chlorhexidine gluconate as a bathing soap can help to reduce the colonization of organisms on the skin, particularly for those who have devices. But also, and I'll talk more about this with Candida auris, there is some evidence that it can, when used correctly following best practice bathing techniques, be effective in the use of reducing skin colonization in Candida auris patients. Environment of care practice are really important. So we want you doing your, paying attention to your cleaning and disinfection practices. Make sure that you're using the right germicide for the right contact time. And I routinely now recommend, as I know a few of my other IPs here, strongly recommend reviewing your products and making sure that you're using products that are part of that EPA List P, which have effectiveness against Candida auris, which is a hard-to-kill organism. So if it's effective against Candida auris, generally said it's effective against pretty much everything else. It's also really important to reduce clutter in your environment. The more stuff that you have out there, the more surfaces are that can be contaminated and that you need to pay attention to. And need disinfection. So, go through, try to reduce clutter, make sure your equipment is well managed and organized, and that you have clear assignment of responsibility and routine practice to clean and disinfect that equipment between each patient's use. I love it when I go into a facility and I see that on their movable wheeled equipment, they have a container of germicide that's kept right there on the wheeled equipment. And it speaks really to that engineering the environment to make it easier for people to do the right thing. If I have to run all the way down the hall to get my hand hygiene or my germicide, chances are I'm not going to comply, and we're going to miss those opportunities. And then the other thing that's important is really part of a larger conversation around water. But you also want to be keeping an eye on your wastewater sources. We know that sinks have been strongly associated with MDRO at gram-negative contamination. And toilets and hoppers can be a source for spray contamination. But again, you can get more details about that either during an ICAR or during one of our upcoming sessions. So be prepared. You want to monitor your micro results for any single carbapenem resistance. And then if you see it, even if it's not reported yet as a CP, implement empiric precautions immediately. I like to say that it's guilty until proven innocent. And if you actually can get that patient on isolation early, it reduces the number of people that we have to screen if we do identify a carbapenemase producer. So it's always better to err on the side of too much isolation for a short period of time than not at all and having transmission. You want to report that new case to public health as soon as possible. And importantly, know that these organisms can be safely managed and prevented in your setting. And we're here to help you with that. All of the IPs with OHA. So, I always like to say, make us earn our living and, ask for a proactive consult. And then also take steps now to prepare for patients landing at your facility with either Candida auris or CPO. Some other things you can do to strengthen your IP program is participate in the IP Power Hour. If you want to participate, make sure you either send me an email or click on the link and sign up for that distribution list. Enroll yourself and your staff in Project First Line notifications. I have it on my personal phone. I get a little ping every Tuesday morning with a very short, simple piece of a little gold nugget with infection control advice. So it's a really great thing to do. Encourage your staff to put it on their phone or their iPad. Also, I strongly encourage you to really begin doing a surveillance program in long-term care if you're not already doing that. And that's planned for one of our later sessions. So, you know, I have some ideas to help you do that a little bit more simply. And then again, request a proactive iCar. And I think Claire's going to drop a link into the chat for that. So you know how to go about connecting with the IP for your area. If you do get a case that requires a response, remember that you're not alone. Don't panic. We get through all of these, and remember that a single case will trigger a public health response with us. And that it typically includes surveillance swab collections, which we support you through. Sometimes on site, and other times just coaching, depending on what your needs are. And then it also includes a responsive iCar to assess risk for spread and how we can help you close gaps in your infection prevention program. So in summary, you know, we can act now to prevent spread of these organisms in Oregon. We've had few outbreaks involving CPO and Candida auris. And that's largely because of our ability to detect them and the robust response that we have been working with facilities that have cases. So again, you're not alone. We are a team and are available to partner with you to assess your program, perform screening, and provide education. If you have questions, please reach out to one of our wonderful team. Evelyn is amazing and a great education resource, as is Heather. And then Elizabeth is my counterpart in Eastern Oregon. I think she had to leave because she went to the APIC meeting. And then, of course, me. So thank you. And I will take any questions and open chat right now. We'll stop the recording, Sandra.